Good morning, everyone, and thanks so much for joining the Clallam EDC Coffee Chat, Coffee with Colleen. We are really pleased to have Darryl Wolfe join us this morning, the CEO of our hospital, Olympic Medical Center, and he's going to talk to us about what's happening at OMC and what is going to come before the voters this November. So few items before we have him take it away. Will you please keep yourself on mute in order that we don't hear any background noise inadvertently. And then also, if you have any questions, if you'd like me to read them, put them in the chat, or alternatively, you can raise your hand. We like this to be fairly interactive, and I will call on you and you can ask your questions of Darryl. So with that, Darryl, I'll let you take it away. And really, thank you so much for joining us and everything that you and your team does for our community in Clallam County.
Yeah, no, thanks, Colleen. Yeah, you're welcome. Happy to be here. What I'd like to do is, so I'm Darryl Wolfe. I'm the CEO here at OMC. I've been at OMC for going on 18 years, and I've been in this role for a little over 4 years. It's been interesting for sure. And anyway, but I have a few slides I'd like to go over, and then after that, I think I can turn the slides off, and then maybe we can just have a discussion about that. Because really what I talk about today is the ballot initiative. Obviously, I can't tell people how to vote, but I'd like to inform you all on kind of what we're looking at and why we're looking at it. And so I'd like to start there. I'm going to attempt to share my screen. We tested it a few minutes ago, so with any luck, that will work again. So give me a second here. And I just have a few slides. Okay, Colleen, can you see that? Okay, awesome.
You're good.
All right, thanks. All right. So again, today I really want to talk to you about healthcare is on the ballot. And so I'd like to go through a few things, explain why, and sort of what we're thinking, and then kind of open it up for questions about that or anything else you have on your mind about OMC. And I think, as most of you know, and it's been widely publicized, OMC has been in a rough financial situation post-pandemic, and we're looking at all options. So I'd like to just go over a few high-level things. We are a public hospital district. Our actual name is Clallam County Public Hospital District Number 2. But over the years we've changed names a couple times, and now we're officially Olympic Medical Center. But we are a local taxing district. Public hospitals, as I think most of you know, we turn no one away. If you're uninsured, you can pay or not. We will see you and we will take care of you. That is our mission, and we will continue to do that. But we are a local public hospital, and I think that's an important distinction versus a not-for-profit or a for-profit entity. We have many of those in our state as well. But anyway, as part of that, there is the tax base or the property tax payments from the county have always partially funded us to some extent, and so that's kind of what I want to talk about today. Let's see if my slides will advance. Oh, cool. All right. So the slide before you, that was a picture of our Port Angeles campus. That's our main hospital building here where I'm sitting. We also have the medical office building just across the way. We also have a couple of other buildings here in Port Angeles where we have clinical services. This is a picture of our SQUIM campus, where we have several buildings also, including our cancer center, physical therapy, primary care, specialty services of all kinds, et cetera. But what's happened over the last few decades is, we built a system around what the community's needs are. And again, we take care of everyone, whether you can pay or not. So it's an interesting dynamic that we find ourselves in. But, you know, if you have friends, neighbors, or loved ones that work at OMC, ask them if we're overstaffed. They will tell you, no, we do not have enough staff. We are not bloated. We are not, you know, we don't have boutique services. The system, by, you know, myself and those that came before me, we built it around the community's needs. And I can tell you, having been in leadership here for almost 10 years, you know, every discussion starts with our patients and our community, and what does that mean? We don't pick services based on their economic viability necessarily. We pick them based on, this is what the community needs, and this is what we're here to do. So I think that's also important to mention. Come on, slides. All right. And as I think everyone knows, you know, we do provide a slew of services, but we, you know, we are open 24/7, 365 during the pandemic. We didn't close for 1 second. We were here. Our ED stayed open. We still delivered babies. We did surgeries that the governor would let us do at times, but, you know, we never closed. We are here for you every single day. And despite, you know, a lot of folks that do seek care elsewhere, you know, we see about 1,200 people today will hit our system. That's people in the inpatient units, that's ED visits, that's people using lab services, imaging services, and so on. So we have a lot going on. And again, we're taking care of the entire community, regardless of, you know, kind of their ability to pay, what kind of insurance they have, et cetera. You know, so here's some stats. You know, we do see about we see about 70 to 80 patients a day in our ED. Sometimes that's 100. And, you know, we manage trauma cases here. We are a level 3 trauma center. But that means you have 24/7 access to orthopedics, anesthesia services, general surgery, et cetera. We delivered about 400 babies last year. We have about, you know, on any given day, we have 40 to 60 patients in our inpatient unit each day. And our clinics, we saw over 150,000 clinic visits last year. Again, that's not every individual patient. Many patients saw us multiple times. We have an intensive care unit where we tend to the most sick folks. And, you know, so we have a lot going on. And in addition, you know, we have a home health agency that is very integrated with many of our services, that takes care of folks in their homes, which is awesome. And what is, I think, I look forward to having here someday, for sure, because I will have my day as well, where that's going to be necessary. And you know, it's here, right? We have a hospital that's here, as close to home, and we take care of everyone. We don't have the ability to say, you know, you're on Medicare, I'll take you. You're on Medicaid, you go somewhere else. You have commercial insurance, I'll take 3 of you because you pay better. We don't have that. We are forced to take care of everyone, which is our mission, and we'll continue to do it. But we can't really manage our patients. We can't manage our revenue stream. We have to take what comes to us. And as many of you heard me say, you know, 85% of our patients are on some sort of government payment system, which pays us less than cost. So I won't go into all that. Many of you know that. But also, it's an ecosystem. I mean, everything works together. There's really no boutique thing that we can just jettison. You know, the physical therapy works in coordination with orthopedics, which works in coordination with anesthesia, which works in coordination with our inpatient unit. So it's very much an ecosystem, and not just here, but across our state. Bed capacity in our state is actually fairly low, relatively speaking, compared to other states. You know, and facilities in the big city rely on us to try to take care of patients here the best we can, because we can't always transfer patients to larger tertiary centers. So, you know, and I have a friend who recently passed away, you know, and I went and saw him a few times in his last months, and he, you know, unfortunately, he was pretty sick, and he spent a lot of time in the Seattle hospitals that did have more acute, you know, because he had pretty acute needs that we weren't able to deal with here. But he kept saying, I can't wait to get back to OMC because at least I'm close to home. My family's nearby, my people, you know, my wife can come see me more easily, et cetera, because we can do a lot here, and we intend to keep doing that. Our employees, you know, I'm still here because of our employees. I've, again, been here almost 18 years. OMC employees come to work every single day to take care of their friends, their families, and their loved ones. And you guys, right? If you know them, you know what I mean. My kids were born here. My wife was born here. I'm still here because of the people. And I think, you know, for us to continue to recruit and be competitive with a workforce that it just by its very nature has to be highly trained, you know, we have to remain committed to those folks. We have not laid people off, but we do have over $120 million a year in payroll here. And that's a huge economic driver. And many of you, I know, involved with EDC, you know this as business leaders. And we are the largest employer in the area. So it's our most important asset. You know, we have, you know, due to some cost containment measures, we have reduced our FTE count by almost 100 over the last 16 months, mainly because, you know, we just haven't replaced key positions, especially that are not patient care facing. We remain focused on recruiting for the folks that are seeing patients. But that said, a lot of what I would say other services, they're not patient facing, are important to the throughput that we need through our facility. Anyway, we have through attrition, we haven't had layoffs, as I said, but we have through attrition reduced our FTE count by almost 100 between beginning of 23 and current. So we are doing all we can on the cost containment front. So Proposition 1, and just a quick correction. This is going to be on the ballot on August 6th, not November. This will be on the ballot on August 6th. Again, as I mentioned, we've long had an operations levy in place at OMC. The current levy has provided us about $5 million a year of funding, and that was last lifted in 2008, about 16 years ago. This isn't something we do often, nor do we plan to do this often. But we are going to the voters in August, and we are asking for a levy lift. And again, I think what the goal is to keep all the things that I just talked about going in a very challenging environment for healthcare, where the payment systems are difficult for us because we are rural, but we're it, and we really want to keep our critical services vibrant and growing, and that 24/7, 365 service is just essential. And again, recruiting the workforce that we need. I mean, we're doing a lot of work, as many of you know, through our foundation and elsewhere, to recruit our own. That said, they do need training, and we're not going to train necessarily everyone ourselves. That's not practical, but you need RNs, you need physicians, you need lab technology folks, so we really have to recruit and retain a very highly skilled workforce, and that's getting more and more difficult with a shrinking workforce or shrinking numbers overall. And the levy would give us, a lot of flexibility and future-proofs us to some degree on. It just keeps, it would do a lot to keep us more vibrant and more sustainable for the long term, to continue to meet the needs of the community. So that's really why we're doing this. And it would help us to the tune of about, the current levy is about $5 million a year to OMC. And this would raise it to close to $12 million per year to OMC. And it really is designed to just continue to support those core services. What a lot of facilities across our state have done, unfortunately, and with difficult financial times, is the first thing that they seem to close is labor and delivery. It's not a profitable thing, but it's a necessary thing. And again, with 400 deliveries here, I don't have that option, and we will not do that. But that said, a lot of the services that are not well funded, let's say by the government payment systems we rely on, they are necessary for us. We provide over, in 2023, about $7.5 million in care that was, we call uncompensated, that covers for those folks that, perhaps they don't, their employer can't provide insurance for them. Perhaps maybe they're not covered by Medicaid, Medicare, and some of their payment systems. There's a lot of situations where folks need that 24/7, 365 care. So anyway, I don't want to go too deep into it, but really, this is on the ballot. These are some high level reasons why we're doing it, and I think it's important. And I think it's a lasting contribution to the healthcare delivery system that we do have here, which I think is critical to the infrastructure of our community. And I think as business leaders, I would assume that as you talk to folks outside in your own circles, they probably want to know what's the healthcare like in the area. And we want to be sure that answer is it's great. And we do all we can to support it, and it's vibrant and it's growing, and we want, we're flexible in meeting the community's needs. So anyway, thank you for listening to my slides. I'll turn those off and answer. Colleen, I guess you and I can. When does the coffee show up? This was Coffee with Colleen. Is coffee time? I'm just kidding.
No one's ever asked me that. And I've switched to these protein drinks in the morning.
Okay. All right. So slides are off. I went through that pretty fast. But again, I think we're at a very crucial point in our history, and we are looking for as much support as we can get from the local community, and appreciate what we do have, and think this is a multi-pronged strategy for us as far as making sure that we are sustainable for the future. So anyway, with that, I'll stop talking and answer questions, Colleen.
Great. Thanks so much, Darryl. So you said that, and by the way, if anybody has any questions, put them in the chat or raise your hand. But I have a few to start with.
Sure.
So you said we were at $5 million annually, and it's been flat at that rate, correct, since 2008?
Well,
and
there is just a caveat to that. We're allowed a 1% increase per year with the budget, and most years we've taken that. So it may go up a small amount each year. It's usually around, like 1% is the max. So between 30 and 40,000 a year, it has gone up over since the 2000.
Okay.
It's kind of a technical
thing,
but yeah,
slightly increased. And and so for other rural hospitals about our size, what is it typical that $5 million would be an amount, or are you on the low end, the high end? Can you describe that?
Yeah, no, we're in the middle. I think it's the pennies per thousand is really, I think, what you're getting at. And that's, where we are with, the allowable limit is 75 cents, which is what we're asking for with the proposition. And I think, Forks Hospital's there, I know as of recently, but most public hospital districts are near that upper end, especially in the last few years as they've tried to, and not every community passes these, and not every, so it's not an easy question, but right now we're kind of in the middle, I guess is what I would say.
Okay. And what percentage of your patients come in that are categorized as uncompensated care?
About 1%.
1%. Okay.
Yeah. Right now, in terms of on a revenue basis, it's less than 2%. It's between 1% and 2%.
Okay, good. So Stephen has his hand raised. Go ahead, Stephen.
Hi, Steve.
Great. Hi, Darryl. Yeah, I'm definitely going to be supporting this levy because I want to support my community here and the largest employer in my community. But it does still feel like a government issue. So can you talk a little bit more about what we're going to do to fix the viability of the overall hospital? It doesn't just seem like this is something we can take care of locally. We need help from Olympia and DC. So can you talk a little bit more about the bigger picture and turning the overall viability of our hospital back to profits?
Yeah, no, great question. Happy to answer it. Yeah, so what I will say is at the state level, the one of the big wins in Olympia last year, and I know Representative Theringer's on at least, but is an improvement in what's called, and I know Eric's on from WISHA, but the Medicaid SNAP improvement, and I think we may have talked about this a few months ago, but that's just an enhancement in how we're paid from Medicaid. I mean, that is over a $10 million improvement to OMC starting this year. So that's happening sort of, it's slow, but those funds are starting to reach us. So that's a huge thing coming our way this year. It hasn't fully manifested itself in the financials, but it's coming. So that's a huge thing on the state front. the federal, in my, 62% of what we're doing is for Medicare patients. So, in fact, I was in Olympia 2.5 weeks ago, and, we continue to beat that drum. We are working with the state delegation in DC on what I would call it an interim. It's not a fix, it's an interim policy improvement, I'll call it that, which would help us the way we're reimbursed for all of our inpatient care, which is again a big piece of what you all will rely on us for. But you're right, and unfortunately, I won't opine on the craziness of DC, but I just think it's a tough time to get a lot of things done back there. But we're going to try, and we are all in on a strategy to try to at least come up with a way to lengthen the runway, if you will. It won't fix all of our problems, but what it will do is create a better reimbursement stream for, again, all those inpatient services, which is, it's probably a $10 million pickup for OMC if we can get it across the finish line. But it's an uphill push for sure. And but I think the work at the federal level will have to continue probably for a long time. It's not a one and done. But so we are actively engaged. OMC. There's a few other hospitals like us in the state that are rural like us that don't have access to cost-based reimbursement, like some of the more smaller facilities. So we have a coalition of folks that we're really trying to move this needle. And that's really the best we can be doing right now. I think we're doing all we can on that front, but you're right. The feds need to or CMS, who kind of is the oversight of Medicare, really needs to step up, and we are doing all we can to force that issue. So good question, but we're fully engaged on all those strategies.
All right, good luck.
Yeah, thanks.
Thanks. Dr. Maxwell.
Yeah, hi, Darryl. Thanks. Good presentation. Nice, concise, and clear about a very complex thing. This isn't really a question. It's just really just a a statement of support, and just to kind of underscore that what you said in your slide to begin with, that healthcare is on the ballot. That is absolutely right, because it's about OMC, but it's not just about OMC. As we've talked about you've got a lot of community healthcare partners where our missions are not only aligned, but they're interdependent. And I know our organization relies on it, and all of our providers and our patients rely on the availability of high quality, accessible services that OMC provides. And I don't think everyone really fully appreciates just how much you do, and how much, if OMC sneezes, the rest of us have a cold. It's a big deal. Yeah, I think it's important to in the messaging. We're going to fully support it, because it's good for the community, and it's really essential for the broader healthcare ecosystem that OMC is in a strong place financially. And you've got some challenges that we've talked. I've got 10 or 15% of your budget, and I can't, with some of the same challenges, I just can't imagine how you're managing it, the headwinds that you've got right now. So a multi-pronged approach makes a lot of sense, and I think it really is a referendum for the community to say, how much do they value having a locally owned and high quality hospital. Our organization does. So wish you luck. And any way we can help, we're happy to.
Yeah, no, thanks, Mike. And I do want to say, and I've talked to, obviously I see Dr. Maxwell quite a lot, but and many of you others I've talked to, you guys have all I've been humbled by the support thus far. I know it's not a shoe-in, but people have really been very gracious, and so I appreciate your comments very much. And it is ecosystem. We do all rely on each other. If we didn't have primary care for some reason, that's a problem for you, right? And your hospital, so there's so much interdependence, and so I appreciate you bringing that up. Thank you.
Great. Eric, please.
Well, good morning. Thanks, Darryl, for that presentation. Very helpful. I kind of know all this stuff, so I don't have a question. I just want to make a comment on why I'm going to support this levy and why I think it's critical. for our local healthcare delivery system. I think the big challenge in healthcare is Medicare. And Olympic Medical Center, I think, Darryl, you told me you're up to 61, 62% Medicare
Yeah.
as your patients, which is, I think it is the highest in the state for non-critical access hospital. I mean, critical access hospitals get cost from Medicare, but prospective payment systems like Olympic Medical Center get paid a fixed payment rate. And 61, 62% is really high. Most hospitals are 30 to 40%. So that high Medicare payer mix creates a challenge because Medicare pays about roughly 80% of costs. So a business model where you spend $1 on employees and drugs and supplies and get paid 80 cents, it's hard to make it up in volume. Although, I think OMC's trying.
Mhm.
And I think the big challenge post-pandemic has been inflation. And inflation has been dramatic in healthcare, particularly labor. I think drugs, pharmaceutical companies are apparently for profit, and drug prices have gone up, supplies. Just the cost of running a hospital, keeping it open has gone up dramatically. And the American Hospital Association did a study, and from 2021 to 2023, inflation for hospitals was 12.4%, but Medicare reimbursement only went up 5%. So that gap, 7% gap on 60% of your business is significant. And I think this levy is critical to maintaining high quality services locally. And I know I had to take a loved one to your emergency department earlier this year. They got great care, and it was mission critical. I can't imagine living in a community without a trauma level 3 ED performing at a high level. It's very important. And so is the birth center, inpatient ICU, surgery, everything else. I don't want to have to use them, but me, loved one, friends, neighbors may have to. So thank you for all the work you do to keep that rolling. I'll be quiet now. I could talk a long time, but this is a pretty important subject to me.
And clearly you're passionate about it.
It
So
matters.
thanks, Eric. Commissioner Bernard.
While Phyllis is getting on, I've received several texts from people on this call about the errors that I've made so far. And one of them is I was in DC 2.5 weeks ago, not Olympia. So we were in DC and on the Hill. So anyway, but go ahead, Phyllis.
Okay, my apologies. I changed the view, lost my button. I had just wanted to underscore the importance of one of the lines in the slides that you showed, Darryl, that healthcare is a key part of the ecosystem. When I served on the National Advisory Committee on Rural Health, it was very clear to all of us that the hospital in a rural area is the anchor of the entire community, at least if the community wants to continue to be alive and to thrive. If you want to attract people to come in, like apparently we have a lot of people who have some means who are moving into this area, well, fine. They expect to have really good healthcare facilities close at hand. They don't expect to have to travel 45 minutes, an hour, perhaps 2 or 3 hours in order to get the health care that they expect at the level that they expect. That's what we are able to provide now. If we want to keep younger people who are going to help build the economy, who are still growing their families and growing the connections that we all have together here, then we need to have a hospital with its full array of services that are available. And when one goes to, I'll just say this part as a former registered lobbyist for public hospitals. When a public hospital approaches their congressional delegation, when they are able to show that this is the kind of support we have locally, that our people are with us, our people are for us, they have invested in us as we are investing in them, that makes it a lot easier argument to make when we're speaking with our members of Congress. Heck, I was able to do that just by simply showing who showed up for us at the polls. What was the percentage? And that could be very, very, very persuasive. It helped to get us the federal backing for hospital mortgage bonds that have been essential for building out facilities throughout the United States. What we do shows up in DC. What we do here shows up in Olympia. And as we recently, sadly, experienced with the potential closure of the McKinley Mill, we are all so interconnected and we have to show up for each other. And I am hoping that we will all show up and do what in our good conscience tells us we need to do for our community by showing up for us on August 6th. Thank you.
Great. Thank you, Phyllis. Jim, you have your hand raised? Please.
I do, Colleen, but if you want to get to some of the questions in the comments before I ask my question or questions, go ahead, please.
Okay, let's see. So Debbie Houston has asked, what's the current rate per thousand? And then also what will that, oh, and then it'll go up to 75 cents per thousand, correct?
Yep. Yeah, it's currently at 0.317. So about 31.5 cents roughly per thousand is the current rate. It's just because of, it was higher, but as the values have gone up, you get a, so I won't, so yeah, it's at 31.7 currently.
Okay, thank you. And so generally, if I remember correctly, in 2023, the hospital lost 16 million. And with this no, that's not correct.
No, we lost 16 million in 22. We lost about 26 million in 23.
Ooh, ouch. Okay.
I hate to say that out loud, but that's the truth.
Okay. All right. So, and let's see. So with this increase of 7 million, that cuts into that loss, but you're still at a negative 19, and then 10 million from the state, not knowing all the other factors, it seems like you'll still be potentially at a negative 9. What are the other ways you're attacking this?
Yeah, no, good question. And so, that's kind of more the here on the ground stuff. I mean, that's really the kind of operational stuff that we're doing. Again, we've tried to reduce the workforce to the right size. That helps a little bit. And again, we did that through attrition. Obviously we've lost some due to retirements, some key provider specialties that we are rebuilding now this year that we did not have last year. That will help. We're looking at, and again, a lot of what we do internally it's all documentation, right? The providers, the nurses, and really trying to tighten that up to be sure that because Medicare will pay you for some stuff if you document correctly. There's, but it's really bringing in the resources to make sure that our providers and nurses, et cetera, are documenting correctly. We just want to get paid for what we're doing. And so, but there are strategies where we can do better. And there's that. And I think, obviously, we've looked more deeply at our supply chain and kind of our supply costs. We've identified, I think in the last 8 or 9 months, about 750,000 in savings there. So there's a lot of smaller pieces, kind of here on the ground, that we're looking at that are, some are revenue increasing and some are just, more a better expense management. But our overall expense ratio, so the expenses per day to run OMC is around 700,000 a day. That was but it was 750,000 in the beginning of 2023. So we reduced that significantly. So through 23, we have had improvements, and we will, kind of continue to ride that. So it's a lot of different things here on the ground. But again, it's a multi-pronged thing, because you're right. If you just look at the raw math, but again, here at OMC with operations, we are looking at, millions of dollars in savings on all the initiatives that we're working on currently. So does that answer your question?
It does. Thank you. And it kind of speaks to the question Paul's written. Can you discuss the comparative impact of the levy on the cost per thousand in property taxes, let's say for a $500,000 home? Also, what your contingency plan is if this levy is not?
Sure. Well, I think as far as the ratio, what I looked at, and again, this isn't official, this is Googling, but the average property in the district was around 300,000. So that's about $11 per month increase, $130 per year, roughly. So for 500,000, that would go to Paul's question. It would go up about $200 per year, so 30, or about $19 a month, something like that. So, so I was trying to think of a really great slogan on, for, a Starbucks a month, you support your local hospital. I didn't quite get there, but I did buy my son a really fancy Starbucks the other day, and it was $9, for which I don't understand how he got to that. But anyway, so for a little bit of Starbucks and a little bit more, per month, that's the impact. Anyway, that's not my good slogan, but it was kind of a try. And then, so that was that. And as far as the contingency plan, I mean, I will be frank. I mean, everything's on the table right now. I mean, we've talked about the losses again, which I hate to say out loud, but it's accurate. It's true. We are in a really unsustainable position. And I think if the levy does not pass, we were going to have to look at other options. And the other options that are available to us are, there's really two. And again, I hate to see this all loud too, but I got to be honest with you guys. That's, if anything, I'm honest. We shrink somehow. We start cutting services and figuring out how to right size that way, which, like I said in the intro, there's nothing here that's extra. Something that's critical to one of us is gonna have to leave. And whether that's, that could be lots of different things, and I won't speculate. We've done a portfolio analysis of all of our services. We know where we make $1. I mean, we know where we don't. And so we'd have to shrink. And I hate that option. That's a terrible option. The other option is we seek more meaningful partnerships somehow, where we have more resources at our disposal to continue to function the way we have. Because my personal mission and the mission of this role is to maintain what we're doing, not to shrink. And so to keep all of this going, because I think what we do have running right now is what the community needs. So cutting that back feels very wrong. And to keep that going, if we're not able to on our own, we've long had partnerships with Seattle Cancer Care Alliance, with Swedish, so we may have to expand those kinds of partnerships to keep us whole. That's, if there's a contingency plan, those are the two. And I hate both of them, but we will do what we have to do to keep everything going and keep care local here.
So at the top level, when you say expand those partnerships, it doesn't sound bad, but I think what you're maybe saying is that you would have to have them provide those services outside of our county.
Or bring
Is that what that means?
Or bring them in. I mean, that could take a lot of forms, Colleen. I mean, it would, yeah, or we have another entity here helping us, keep this place running at current capacity. I don't know what that looks like. We're going to start looking at those options, because I think it's irresponsible to, but we don't, that's not where we want to go. But I think we need to just be honest with ourselves. If we can't make changes at the federal level, and let's say the levy doesn't pass, if the headwinds continue, we can't continue to lose money at the rate we have been, and so we will have to look elsewhere. And again, I don't know exactly what that looks like today, but that's what we would have to do.
Mhm. So I've heard Commissioner Nutter talk about the fact that that we've in the city of Port Angeles, you have an exceptional pool, Shore Aquatic Center, run by a fellow friend and commissioner of mine, Steve Burke. But can you compare those levy rates to what we're asking from the hospital?
I
Or,
cannot.
or John, do you want to talk to that?
Yeah, I don't. I want to start by saying I love the pool and I like Steve a lot. So before we go any further, but no, I'm not really up on what the pool. I mean, I can pull out my tax statement and tell you what it is, but I'm not up on that. Maybe John has some insight.
Yeah, I have a little bit of insight into that. I make fun. I like Steve as well, and enjoy working with him. But right now, I will be the first to tell him, I spend more on the pool than I spend on the Port District. So the pool from a cents per thousand is probably pretty close to where the hospital is right now, or maybe slightly higher. But they are also constrained by basically the geographical boundary of the Port Angeles School District, whereas OMC is basically from the Diamond Point, Jefferson County line clear out to the other side of Lake Crescent, Fairholm Hill. So we have a much larger population that we have to take care of. So I love spending money on all three, but as a board member, OMC is by far the most critical one. They are our economic driver. They are the lifesavers in our community. And I actually hired Darryl when I was working there. One of the best decisions I ever made in my life. And, very, very proud of I started there in 98. So that's too many, 24, 25, 26 years I've been associated with OMC. It's a great organization. I'm fielding phone calls every day of, well, can't you just cut expenses more? No, if you look at the average administrative expense per patient day there, it's already one of the lowest in the state. We are not in a position where we can just cut expenses to balance the books. Darryl's making some really strategic decisions, like really having HR focus on replacing expensive travelers with people that we hire full time, because they are frequently half the labor cost when you're able to get away from that traveling nurse or traveling doctor perspective. So for the 7-member board, it's all hands on deck for us as well. And Darryl has to live it every day. So thank you, Darryl, for what you're doing.
Great. Thanks, John. Jim, do you want to ask your question now?
Yeah, I do. Thank you. Appreciate the presentation, Darryl. Let me just make sure I heard a number correctly. Did I hear you say 85% is your percentage of your payer mix that's Medicare, Medicaid, and TRICARE? Or did I get that wrong? I'm not sure I heard that number correctly.
Unfortunately, Jim, you heard that correctly.
Oh, wow.
There's a few others in there that we consider government payment that are smaller, but yeah, those are the, you got 62-ish that are Medicare. You got about 16 Medicaid, and then we have the TRICARE and some of the smaller plans, some smaller government plans as well. But yeah, we're our commercial payer mix, which is the part we really would like to grow, is around 14%, which is, and I think, used to be, it was, a couple of years ago, it was higher. I think there's some shifts locally in how people were insured. We're trying to, one of our strategies is trying to figure out, where is the commercial payer mix and how do we chase that? Because they pay us better than the 80 cents on the dollar that Eric talked about. But no, you heard me correct. Thanks.
Okay. Well, the last number I remember hearing was 82%. So is that a couple of follow-on questions? Is that a demographic shift, do you think, or a shrinkage of private payers? And I would observe that school districts, the county government, the hospital are all classed as private payers because you have, as part of your compensation package, you pay your employees a benefit that they get as healthcare. So.
Well, not exactly. And I think, I can't speak for the school district. I know they changed plans and I believe they're on a plan that's sponsored by the state, which is
Right.
a fixed payment. So that's not that would not be considered, that would be considered a government payer. And same for OMC. We were commercially insured for a couple of years because we had some, well, it's a long story, but anyway, it was cost prohibitive to stay that way. So we went back to the state's program that we were on for many years. And I believe the
see.
school district did the same. So part of our payer mix is that shift. But otherwise, I think the demographics are such that the Medicare, Medicaid population seems to be growing and the commercial population is not,
That's not a good trend, I don't think. And
no.
the upshot of that to me, and contest this if I have this wrong, the upshot of that with that particular percentage of payer mix is that you're always going to be financially close to the edge, even in the best of times.
Yeah, I think, we've done some of the, dredged through a lot of historical data and with a lot of our federal work we've been doing. And, we 2 or 3% margin was quote, good times here.
Yeah, right.
Really not. I mean, I think if you, this is a serious story. I mean, I've got some friends that work in other industries and we talk about 2 to 3% margin and they start laughing. They're like, you're insane. How does that work? I'm like, well, we're public and blah, blah, blah. If you work in most any other sector of the economy and you talk about being happy with a 2 to 3% margin or calling that sustainable, it's really, so I think we've been challenged for a long time in this payer mix discussion. I've done some public forums in the last months and people say, they've been talking about this for years. I'm like, well, yeah, and we have been,
Right.
but we pick. So no, I think it's been strained for a long time and it's just reached to a point where the inflation relative to we've reached, those lines have crossed where.
Yep.
So yes, the answer is yes, Jim. We will continue to be, which is why we're working so hard on the federal
Yeah.
piece of this, because it's such a big part of what we do.
Yeah, I totally agree with that strategy. That's the only strategy really that you have. The last specific question I have is, do you know off the top of your head what percentage of your overall expenditures is for compensation and benefits? It's got to be pretty high, I would think.
Yeah, well, I can tell you it with contract labor and the other components. Yeah, well, I haven't checked it recently, but it's over 70% now.
Okay.
We had a strategic planning goal for many years about 62% was kind of where we wanted to be. But with the pandemic, the shift occurred where we had to get a lot more contract labor to cover all services. And that's not just RNs, that's clinical positions across the organization and as well as providers, locums providers. So yeah, we're running more in the low 70s now, or around 70% versus the low 60s.
Yeah, well, the conclusion from that for me is that you're competing in at least a regional market for labor, for talent.
Yep.
If not a national market. So you're swept wherever those currents are going to take you. You don't have a lot of flexibility then as far as payroll costs, because that's going to be dictated largely by regional or national markets for that kind of talent that you need. So.
Yeah, no, I think it's someone once said, all of our expenses are subject to the free market, but all of our reimbursement is in a sense capped. So,
well, the grand conclusion for me is that everything is at the margin. The cost reduction is a marginal improvement. Tax increases are a marginal improvement. Payer, I don't think you have control over payer mix. We are becoming a retirement community, and that's just the trend here, has been for a long time. Mm-hmm. So everything at the margin either hurts or helps. You lose a payer like the mill employees, that hurts. Yep. You lose timber harvest money, that hurts.
Yep.
Et cetera, on and on. So the point here, I think, is that the community, and I'm going to be a supporter of the levy. I'll just be plain about that. I think that's a tough decision for a lot of people because our household income here is substantially lower than the statewide number. So it's going to be a hard sell for a lot of folks here, I think, but it's necessary because we can't do without an adequate healthcare system as a pillar of our community and as a pillar of our economy here. We just can't go without that. So I'm just trying to rehearse in my mind some of the elements of the pitch to make sure everybody knows what's at stake here as far as OMC's financial position is going forward. That's the important thing.
Yeah, no, thanks, Jim. And I think I'll be speaking to your group here. I'm speaking a lot of places in the next 6 weeks. We'll be bringing some basic information for you to have in your pocket,
Yeah.
if that's helpful. So just so you've got the key talking points and that kind of thing.
Yeah. Well, you probably just heard some of the questions I'm going to be throwing at you.
No problem.
At the end of the month.
No problem.
So Darryl, another question in the chat was, how has the lack of housing affected recruitment for OMC?
Yeah, good. I don't have statistics on that. I know it is a factor because I mean we have jobs here that pay pretty well. You know, these are highly trained professionals. And the lack of housing is a factor, but I couldn't tell you if it's, 10%, 20%. But I do know it is a factor for many to find housing. And I'm not exactly sure, but I have heard among recruiting that it's a factor. And I think it is for all of us, everyone on this call that we're all, I think, scratching our heads on how do we solve that problem. But it does impact recruiting, no question, but I couldn't tell you how much.
Okay, thank
accurately.
you.
Yeah.
And so we've heard people say that, why don't you just become a critical access care hospital like Jefferson?
Yeah.
And because their reimbursement rates are at cost rather than 80% of costs. Can you speak to that with the?
Yeah, well, I think it's a capacity question. I mean, I think that is, at least in my mind, that's option Z, is to go to 25 beds. And I know there's creative ways you can get to a little bit higher, but like I said, I mean, I think I wasn't joking. I mean, we're going to have 1,200 people touch our system today. And I haven't checked our census yet today, but it's often in the 50s. And so I guess what I would say is, if we're a critical access hospital, I wouldn't want to be the 26th patient. And I also, the capacity across the state is constrained in a way it's never been before. So the option to just transfer, which may have been perhaps a little bit easier, or there may have been more capacity at, Swedish, VM, St. Mike's, down in Kitsap, whatever, they're full. I mean, if anything, we're trying to figure out how do we make our services more robust to keep people here longer, because there's nowhere for them to go. So I think us shrinking to 25 beds, unless there's a whole bunch of new capacity somewhere else that we can send people, would be a bad idea. But again, what we ultimately need is cost-based reimbursement for healthcare facilities that have more than 25 beds, which is what I would like to see us do and we will push for. Will that ever happen in my lifetime? I don't know, but we'll try. But going to 25 beds with a community this size, I think, is just a really bad idea. And if that's the only option left to stay open, we'll talk about it. But we're not to that point yet. I think I would rather figure out a strategy to, again, work with others to maintain the capacity that we have, rather than going to something that would, I mean, think about the job losses, think about the loss of care, the loss of specialists. I see that as a devastating thing for our community to go to that size, frankly.
Thank you. Steve, go ahead. Steve, you've got your hand raised.
Sorry, I had you on mute. One of the indicators that you've mentioned in the past as a measure of your progress has been the number of travelers. I'm just curious, how has that tracked over the last couple of years? Where is it today? Where do you think it'll be at the end of this year?
Yeah, no, good question. We were, I think our high number was 80. And this is non-physicians, this is just staff. And this is, again, nurses, physical therapists, lab techs, et cetera. We're down, we've cut that about in half. We are about 40 or 42, I think, right now. So we've cut that in half. And the other thing that's been helpful is the rates have come down. There seems to have been a softening in the market for travelers. So the prices that we saw during the pandemic have come down to what we experienced pre-pandemic. So while still more expensive, they are becoming a slightly more affordable, but really we want permanent staff. But anyway, we've essentially cut that in half, Steve, and our goal is to be at 20 by the end of the year. And we're shooting for that, and we're gonna do all we can to get there. But I wouldn't promise that, because we still have to continue to function, but we're trying to whittle that down aggressively.
Thanks.
Thank you. Debbie, you have your hand raised? Debbie? Not hearing from Debbie.
There we go. I found the
Okay.
unmute button. One of the gentlemen mentioned the rising costs in the medications is also an additional expense. When was the last time that Medicaid had to produce an audit as to what they were paying for those medications? I just had a recent incident that I could buy my son's insulin at $144 for a month's supply, and they had been billing Medicaid $640 for the same insulin. I think we need to, address the elephant in the room, that the medications we're being gouged in some of these areas. What are your plans to address those rising costs?
I'm trying to, so is it, I'm trying to understand you're trying to figure out how to answer your question. Is it a matter of what we're paying for medications, or is it what we're charging, or is it the
What you're
Medicaid?
having to pay, which is adding to your losses. If you're having to, if you're billing Medicaid $640 for a month's supply of insulin, when it should be costing you $144, I mean, that's $500 added onto your losses. So, I'm not understanding how Medicaid is being asked to reimburse costs that are so out of line with free market.
I'll try to answer it, but you may need to just send me that question offline, because I might have to do a little research,
Okay.
the details. But no, I think if you look at OMC's financials, you look at the gross revenue is around, round numbers, we'll call it $500 million. We get paid about $250 million, round numbers. So what you're talking about is, off the top. So we talk about our budget. We don't even talk about gross revenue, because it's not a meaningless number, but we get paid for the services we provide 85% of the time. So I think what you're looking at is the discrepancy between, what we're actually earning versus what, and again, like Eric talked about earlier, we're getting paid way less than our costs. And I would say until the SNAP program, which we talked about earlier, started, which is a Medicaid program, Medicaid was paying us about 60% of our costs. They were kind of our lowest payer. So, Debbie, I'm happy to have this conversation if you want to continue it. If you have a specific example, I can maybe dive into that a little bit more deeply and try to answer your question better. But my high level answer is what we charge and what we get paid, you pretty much cut half or more off the top.
Great. Thanks, Darryl. So Bobby has her hand raised, and I think we'll have to call that the last question, just after 9. Go ahead, Bobby.
This wasn't a question as much as it was just a follow-up to that last question. All government programs and commercial contracts have their own rates established with, you know, how they reimburse for pharmaceuticals or what they pay for it. So it's just a very complex, it's a very complex system, which is why it's so hard to get to a solution of decreasing those costs.
And we don't get to negotiate it. They tell us what they're paying us. So
Yeah. Yeah, I understand that. The way of the federal government. So thank you so much, Darryl, and everyone for joining us today. It's a really important topic. And yeah, August, on the August ballot, we'll see how it turns out. I feel like with the number of retirees that we have in our community that we'll probably get this to pass because everybody relies on our hospital. And as you age, the hospital becomes more important to you. So with that, again, thank you so much for taking the time to explain everything. And if Colleen EDC can help in any other way, just let us know and we're happy to share information out for you. Got about 9,000 people on our mailer list and we can get some information out for you.
yeah, the final thing real fast is just that, you know, as we work on this federal strategy, you know, when we start talking about actually drafting legislation and we have a bill number and things like that, and, you know, I would love to engage you guys again and, you know, start writing to Senator Murray, Senator Cantwell, Derek Kilmer et al., and just start, you know, kind of hammering that when we have a clean strategy, which we would like to have later this year. So anyway, thank you for having me. Definitely invite me again. Thanks for your time.
Okay, thank you for all you do. Thanks, everyone. Have a great day.
Thanks, Darryl.
Thanks, guys.